Consultant orthopaedic surgeon Andrew Chambler will be talking to you about the life of the shoulder. Mr Chambler has worked with Bath Clinic for a number of years and we are delighted to be working with him. Mr Chambler will be supported by one of our senior physiotherapists, Kim Acton, who will talk to you about the role of a physio in the management of your shoulder. As we go through the presentation, please feel free to drop any questions into the chat and we will pick them up at the end of each session. I'm going to hand you over to Andrew Chambler.
Thank you. Oh, great. Thank you very much, and thank you for tuning in on this blustery night that we're about to have. They asked me to talk about the shoulder, and there's a lot to talk about, and there's lots of different conditions, but we thought we'd try and put them all together in terms of the life of the shoulder, in terms of how they affect us at different times of our lives. I think I'd like to initially talk a bit about, if people haven't heard of me before, but this is me. I trained up in London and in Imperial College with shoulder fellowships in Oxford and in America and travelling around Europe. I was a consultant for 10 years at Yeovil and then moved up to the Bath region and have been, as Lucy said, involved with the Bath Clinic for about 5 to 7 years. The aims I think we'd look at this evening is perhaps understanding a bit of shoulder anatomy for you to then be able to clarify the different conditions and which areas they affect. Then some of the symptoms you might be getting from your shoulder problems to then delineate what might be going on. And then actually looking at some common conditions in terms of the youthful shoulder, the working shoulder, and then the retired shoulder. And as Lucy said, if you can put up some questions during the talk, then we can discuss those with Kim and I at the end. So anatomy, quick run through. These are the bones. You have your clavicle, which is your collarbone, your shoulder blade, which we call the scapula, and then the humerus, which is your arm bone. You can see from the joint itself, it's a ball and socket joint, but unlike the hip, it is a very shallow socket and a big ball compared to it, which will come on to why it ends up being quite unstable, but allows a great range of motion. You then start putting in some of the constraints around the shoulder that helps it stay in place, and these are the ligaments that are within the capsule of the joint and a surrounding cartilage of the socket, which we describe as the labrum, which acts to keep the head of the humerus in place. You then start getting complicated, which I won't bore you with particularly, but here are all the muscles that come in, and the main muscles that we deal with are the smaller muscles inside the shoulder, which make up a cuff of tendons, which some of the physios will describe to you as the rotator cuff tendons, which help rotate the shoulder and also elevate the shoulder with the help of the deltoid. But Kim may be able to talk a bit more about that to you later. So shoulder pain, it is very common. About 20 to 30% of you will present to your GP within your lifetime. 50% of those will resolve within 6 months, but 30% will still have problems at 2 years. And it tends to be that, well, it is the second most common musculoskeletal complaint faced by GPs after backs. The areas, sometimes it's obvious, like this picture. But it is mainly related to the joints, to the rotator cuff, which is the tendons that I spoke about, or the actual capsule of the joint in terms of it being too stiff or too loose and in terms of instability. Clearly, we have to think about other areas of the body that may refer pain to the shoulder, such as your neck, other neurological conditions or infections or tumours. But assuming that these are all been excluded, we can concentrate on the origin of the shoulder pain being within the shoulder. This particular case was the actual knife was between the shoulder blade and the rib cage in the muscles at the back of this poor patient, and we were able just to take that knife out and everything was fine. So the useful shoulder. We all do crazy things when we're younger, as you can see by some of these pictures here. I'm not quite sure what that motorcyclist is going to head into, and certainly that baseball player was trying for a home run. But often the common thing in the shoulder is dislocations. As I said before, with the shallow socket, it is very unstable, but gives us one of the greatest ranges of motion of any joint in the body. And the ligaments around the collarbone attaching onto the shoulder blade is where your acromioclavicular joint can often get injured with direct impacts, and people describe as sort of popping their shoulder, which can damage the ligaments around there. So the two main areas, the main shoulder joint and then the smaller AC joint at the top of the shoulder. What we can do with these, as you can see, once the damage is done by that labrum that we showed before gets ripped off the front of the shoulder, the so-called Bankart lesion, which is just named after the surgeon in London that first described it, and that causes looseness of the shoulder in that direction, and people can go on to recurrent dislocations. We can fix this mainly now through the arthroscopic techniques, by where we can you can see on that intraoperative slide, where we essentially stitch that labrum cartilage back onto the joint, tightening the ligaments at the front and stabilizing the shoulder. Sometimes if people damage the shoulder enough to damage some of the bone around it, we then have to go on and move bits of bone around the shoulder to stabilize the socket and strengthen the socket at the front and bring some other tendons around, and that's done most commonly through an open procedure, but these joints can then become stabilized and patients can get back into their recreational pursuits. We mentioned the AC joint with the damaged ruptured ligaments there, and we can put artificial ligaments in to stabilize the joint, give strength back to the shoulder, and get patients back into the sports that they enjoy, and then go on, no doubt, to have other accidents. The working shoulder, which unfortunately I'm at the stage of now, and it's really to do with the wear and tear of the tendons. And these slowly over time can start catching and impinging, as we described it, and that can cause changes within the tendons themselves, generate inflamed tissue, and if it carries on, can lead to actual rotator cuff tendon tears. We can fix these tendon tears, so-called rotator cuff repair, mainly arthroscopically or keyhole as set up here, and we can do this as day case procedures and return the tendon back onto the bone from which it had been torn off, and then rehabilitate it with our physiotherapist to get function of the shoulder back. This is a little bit about how to repair. Moving on from when tendons are completely torn, we often see tears that, or tendons that haven't quite torn yet, so-called partial tears. And there is some new technology out there where we are using bioinductive material to help and support these tendons while they then themselves begin to heal. This allows quicker recovery. And this particular one is made of type 1 collagen, which we have in our bodies, but it comes from bovine cow material, and it beds into the damaged tendon and induces a tendon-like tissue and healing. Again, this is done through a keyhole approach and can be done as a day case procedure, the procedure itself lasting about 40 minutes, and people are out the same day in a sling for a couple of weeks and then start going under the guidance of the very important physiotherapist. I'm saying that because Kim's watching me from one side. Moving on for the frozen shoulder in a working shoulder, another common condition is a frozen shoulder. People may describe this for lots of different pain in the shoulder, but specifically for this, patients develop pain followed by stiffness. So that's the freezing of that shoulder. It becomes very stiff. And then after a period of time, it begins to thaw out and start moving again. The problem is it can take a long time for the freezing or the frozen phase to last, and people can be severely affected by it, mainly through pain and secondary function. Unfortunately, it tends to be seen commonly in females between the ages of 40 and 60, and about 10 to 30% can have it on both sides at the same time. It does normally resolve itself, but it can take up to 2 years. But some recent studies have shown that even after that period, there is still some little stiffness going on, which, although patients may not need to be treated for, may cause some functional problems. There's various ways of treating it, and of course you shouldn't always dive into surgery straight away, and some people can be having some gentle physiotherapy or anti-inflammatory medications, and steroid injections can also help with the pain to allow the patients to wait for the natural recovery. But if this still is painful and prevents the function, then you can consider a keyhole procedure to release the capsule and get the shoulder going once again. Over 90% of people that have this procedure do very well, but again require physiotherapy afterwards. Moving on to the retired shoulder. So once the shoulder's done all its work, it can rest and enjoy some of the older recreational pursuits that I look forward to enjoying when I stop work. But you then start getting into the arthritis. So this is where the joint itself begins to wear out, as it does with hips and knees, and patients develop pain and stiffness, particularly in the mornings, and they cannot then start functioning in terms of looking after themselves in their retirement. There tends to be two types of arthritis in the shoulder, in very simple terms. One is where the tendons remain intact, as you can see on the left, and where the ball and socket is still facing each other and are concentric, as we describe it, but there's lots of extra bone formation, and there's the pain that arises from that as the cartilage diminishes. The second type is you have the arthritis, but you also have the problem that the rotator cuff tendons have worn and torn away, and therefore you have pain and instability and loss of function because of the movement of that joint. And it poses for us shoulder surgeons a dilemma in terms of how best to treat both of these types of arthritis. Whilst there's a conservative treatment, of course, in terms of modification of activity, some physiotherapy can help it, and also injections and other pain methods. If people want to look for restoration of function as well as reduction of pain, then yes, we can look at shoulder replacements. There's not as many happen as hips and knees, but certainly more and more are going on in the UK and around the world. And essentially what it means is that you can either replace the ball with a ball and a socket with a socket if the rotator cuff tendons are intact, or if not, you can switch them round or reverse them into a reverse shoulder replacement, where you put the ball on the socket and then the cup sits on the top of the arm bone, the humerus, to allow the muscles that are left to be able to move it in a, because we alter the biomechanics around the shoulder. Both are very good for pain relief and getting patients back into independent lifestyle, which is obviously very important as we all get older. Some patients that have had them done, this lady gave her permission for me to show this. So she's had bilateral shoulder replacements. The tendons were intact, so we're able to do a like-for-like replacement, preserving as much bone as possible using a cementless type. And you can see her movement is returning nicely to a functional level, and she is pain-free, enjoying swimming, and back into her gardening aspects, which she was particularly wanting to achieve. We mentioned if you have these torn tendons, so we switch the components around, so the ball goes on the socket and the humerus has a cup that puts it on, and this is an example here. And again, with good results with physiotherapy afterwards, patients can get a good range of motion and to be able to move relatively pain-free. The videos aren't quite seem to be working particularly well, but essentially it's showing her doing some exercises that she wanted to show me, whereby I wouldn't recommend this for lots of patients doing with this, but she did it before I could stop her, but again gave my permission to show this tonight. And doing a bit of Joe Wick's workout, which is probably more than I'm doing at the moment. So they work well. They're not without their risks, but these risks are tiny, similar to hips and knees. And overall, the results, well over 90% of patients do very well. The future, we're always looking to improve things, and certainly for the replacements, we're beginning to look now at guided personalised surgery. So this is where we use the patient's own CT scans to allow a computer to help us put in these replacements even better. So the process is the patient undergoes a CT scan. This goes into the computer where it is analysed, and then it goes back into the computer where we can plan exactly the type of replacement and size of replacement and positioning of the replacement to the patient's needs. And then it goes onto a live computer that we can use at surgery. As you can see here, that computer there can find out where the shoulder is of the patient with these tracking devices, and then we can track our instruments, and they can tell us where to put the replacement once they know exactly where the orientation of the shoulder is. Once we've done that, as I said, these tracking devices go onto the instruments, and then we can position exactly where we want to make our cuts of the bone and to freshen up the bone surfaces and actually see it live on the CT scan as we are operating on the patient. And we have this again just shows the positioning and orientation that the computer needs, and then we go through that and we can see the positioning of the screws, and theoretically it gives us a better position for the shoulder, which hopefully therefore will mean that it will last longer. Commonly these can last well over 15-20 years now, as we're watching it on our joint registries, and the better positioned they are, the more likely that they are to survive. So in summary then, it's a complex area of the body. We tend to look after up to 5 different joints within the shoulder, which is a lot more than the one hip that the hip surgeons do, but don't quote me on that. And there's different conditions and different issues throughout our lives, which we've hopefully touched upon. There are treatments available, but certainly one should look at non-operative treatment first. But if this fails, then there are many operations and ways of which that we can help improve the function of the shoulder and reduce your pain in your shoulder. As we said before, there's several surgeons here at the Bath Clinic, and we're always here to have or be a shoulder to cry on. Thank you for listening, and now I'm going to hand over to Kim, I believe. Is that right?
We'll just do some questions.
Okay, great.
That was brilliant, so thank you very much for that. So some questions that have come in. How long after surgery is it before you can use your shoulder again properly?
Very good question, very important. It depends on what you do. Essentially, if it's a keyhole operation where we're just making more space for the patient's tendons, then people are out of a sling after about 10 days to 2 weeks, and then back into normal activity after about 4 to 6 weeks. If you're doing a joint replacement, you'll be in a sling for about 3 weeks, but starting to do exercises straight away, and then wean out of that back into normal activities after about 3 months. But it can take up to a year to get the maximum functional return from shoulders on any type of surgery that we undertake.
Brilliant. And what is the current waiting times for appointments and surgery?
That's a very good question, very important again, which probably someone else could help to answer. But certainly at the Bath Clinic, it is very low. I think I'm seeing patients within about 2 weeks of a referral, and the waiting times currently for me for surgery, once patients are listed, is probably around about 3 months.
That's right. Another one that's coming that might be more directed to me is, how much do I need to budget for surgery? So our shoulder surgery ranges from anywhere between £2,000 and just under £14,000. Obviously, there's quite a lot of different procedures you can have in that, but you get a better idea of cost once you've had a consultation with yourself.
Yes, absolutely. And also one assumes that you have finance packages. Yes. And interest sort of free packages and things that they can look at. Okay. Thank
you for your questions. Please feel free to continue sending them in via the Q&A box, and we'll answer as many as we can. Please welcome Kim Acton, who's our senior physiotherapist here at Bath Clinic.
Hi there, thank you for having me this evening and to join Mr Chambler alongside his work that he does as well. So I just wanted to introduce myself. So I'm Kim Acton. I've been working in trauma orthopaedics for about the last 18 years, but specialised in shoulders over the last sort of 10, 12 years, and mostly here at the Bath Clinic. So starting to look, it's covering a little bit what Mr Chambler said, but we'll whiz through this a little bit. But just talking about the shoulder, in the sense that it is the most mobile joint, but of course that leads into the most unstable joint as well. Essential for what we need, as we talked about, the shoulder's got to move in all these directions. So we need the socket joint to be shallow, but of course then we need to rely on the rotator cuff muscles to provide this stability. And these are all the elements that can go wrong when we're looking at shoulder pain. When we look at shoulder function, and that's essentially what physiotherapists are doing, efficient shoulder function comes from 50% of the shoulder joint and 50% from the scapula or your shoulder blade. So any imbalance leads to compensatory measures, which obviously then, as soon as the problems start to rise, it's going to result in pain and loss of function. So that leads me on to say that really, talking from Mr Chambler's talk, we've been talking about that 30% still have pain or still have symptoms at 2 years, and it's so important that you don't want to be in that group. So for us, we really feel it's getting the right physio at the right time, and that links in with working closely with the surgeons. What we always say is we want to break it down into 3 groups of physiotherapy. We really look at early intervention, and we'll come on to the groups of that as we're talking through the life cycle of the shoulder. Prehabilitation, so that might be any physiotherapy that you get before you might have surgery, and then rehabilitation, which of course is then following Mr Chambler's work after the surgery. So we're looking at early intervention, and let's look at the youthful shoulder. So when we're looking at things like dislocations, hypermobility, it's so important that we look at a stability programme. But that isn't just your shoulder, that's also looking at core work. The shoulders need to have a better base of support. So it's essential we're looking at things like Pilates, yoga. If we can get that core working well, then the shoulder has a much better base to work from. We need to look at imbalance. We need to think about what is tight, what is weak. So what do we need to stretch? What do we need to strengthen? We'll then look at specific education. That might be within school, work, sport, and that might be thinking about posture, seating, position when, what position you might be playing in any sport. So it really be specific to what you need. And that encompasses then looking at a holistic approach. It might be considerations with growth changes, especially in the adolescent group. It might be looking at is symptoms evolving from the thoracic spine through the neck, and that's something we can look at as a whole. So moving on to the working shoulder, more early intervention physiotherapy would give. Certainly early physiotherapy to address, if we're looking at impingement, may be able to prevent any further rotator cuff damage. So it's really vital we start to get physio in as quick as we possibly can. And that moves then on to sort of looking at posture, positioning. So important in this working shoulder, depending on what your job might be. But it's really important that we can start to address what position that shoulder is in. We might look at things like joint mobilisations, soft tissue mobilisations, and the use of things like taping, electrotherapy and acupuncture. And early intervention in the retired shoulder, a bit like Mr Chambler said, really, we need to really look at everything we can. We would encompass everything we've already mentioned, but we also want to talk about when maybe muscles are irreparable, possibly, or that surgery isn't possible or suitable for yourself, then sometimes we talk about the anterior deltoid programme. The anterior deltoid programme is something that we look at to strengthen and use compensatory muscle groups. So that may be something that physiotherapy would cover. And we'd look at strengthening work dependent on what type of situation we're looking at. Moving on to the next session, and when physio would get really involved, is maybe rehabilitation. So you may be at the stage you're contemplating surgery, but obviously, you want to be in that best position prior to surgery. We want to get your muscles, everything, to be the best position it possibly can be in. This in turn will obviously give you the best outcome from your surgery. And we might want to address any issues. So again, musculoskeletal issues. So again, we want you to be in that position, ready for after the surgery. And rehabilitation. It's, as Mr Chambler said, we get involved with you when you're on the ward as a day case, or if you stayed in as an inpatient. And that's looking at sort of specialised physio to provide you with the correct advice and exercise programmes following your surgery. We want you to gain the best outcome from your surgery. It's a lot to go through in that sense, so we want to make sure it's the best outcome for you. We'll provide you with all the advice you need to get back to your activities, work, sport, and in the best condition you possibly can. Also mentioning on that, what we obviously do want to do is make sure we prevent and protect any repairs that might have happened during that surgery, but also to maybe gain early movement, especially with things like the frozen shoulder releases. So physiotherapy at the Bath Clinic. We provide specialist shoulder assessment and treatment here at the Bath Clinic. We look at using a wide variety of treatment options, all depending on what condition and what stages of life that shoulder is at. So that's what's vital to work with. And most importantly, we have these close links with the shoulder consultants here to make sure that we are, working together as a team and to make sure it gives you the best care for you and your shoulder. Thanks.
That was brilliant. Thank you, Kim. We've got some questions. How long after surgery is the recovery period?
That's a good question. It's a bit like Mr Chambler mentioned earlier. It all depends on what type of surgery you have. I mean, that can range from sort of maybe a simpler procedure as a day case would be a couple of weeks, but sometimes as physios we might be seeing you within that year period. All just varies on the condition and all just depends on what you'd require after your surgery. Brilliant.
Would you get the same physio each time you came to the clinic, or would it be somebody different?
Yeah, that's a good question actually. We definitely work very hard to make sure you see the same physio the whole time, and we will make sure usually it's with myself or one of my other colleagues that works with shoulders, so we make sure you see the best physio for yourself, but also trying to keep to the same physio.
And finally, roughly how much does physio cost?
Yep. It's for initial assessment, that's a 45-minute appointment, that's £55, and follow-up appointments are half an hour, and that's £45.
That's brilliant. Thank you very much for your time this evening, and thank you to Mr Chambler and Kim. We hope you found this interesting. If we haven't managed to get through all of your questions, please feel free to contact me. If you have found this interesting today and would like an initial consultation booked in, or if you wish to discuss any of the self-pay options or finance options here at Bath Clinic, please feel free to contact me. My details are on the screen now. Thank you again.